The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/VJP860. Downloadable slides and practice aids are also available.
Hello, on behalf of PeerView Live, this is Dr. Erica Hamilton, and I'd like to welcome you to Moving in Leaps and Bounds towards expanded precision treatment of HER2 or HER3-driven breast, gastrointestinal, lung, and other cancers. Today we have a great faculty that's joining us. Again, I'm Dr. Erica Hamilton from Sarah Cannon Research Institute. We also have Dr. Elena Janjigian from Memorial Sloan Kettering Cancer Center, Dr. Sandeep Patel from San Diego Center for Precision Immunotherapy, and Dr. Nick Wagle from Dana-Farber Cancer Institute, Harvard Medical School. So for part one, navigating the expanding role of HER2-targeted therapies across a range of solid malignancies, I'd like to introduce Dr. Nikhil Wagle.
Thank you, Dr. Hamilton. I'm going to start with a general introduction to the topic focused on the biological foundations of HER2 as an oncogenic target, particularly HER2 activation and downstream signaling pathways, the spectrum of alterations across different tumors, and the role of testing. The HER2 family of transmembrane receptor tyrosine kinases, or RTKs, consists of four closely related members: the epidermal growth factor receptor, EGFR, HER2, HER3, and HER4, also known as HER1, 2, 3, and 4, respectively. Signaling through the HER2 family underpins many of the cellular activities on which cell survival and function depend. HER2 receptors were linked to human cancer pathogenesis more than 30 years ago, with EGFR, HER2, and HER3 all implicated in the development and progression of cancer. Today, we're going to focus our discussion largely on HER2, as well as touch on HER3 a bit. In the late 1970s and 1980s, the explosion of new technologies in molecular biology led to genetic cloning and biological understanding of a variety of steroid and peptide hormone growth factors and their receptors, as well as the development of the concept of oncogenes. Among these discoveries was the identification of the epidermal growth factor and its receptor, EGFR. In 1984, the first evidence for a role of HER2 or HER2, which was named for human EGFR2, in cancer was inferred from the connection to its rat ortholog called NU. The critical moment really came in 1987. In a seminal study, Dennis Slayman and colleagues found that HER2 is amplified in about 20% of breast cancers. Working with the late Bill McGuire and others, Dr. Slayman reported that amplification and overexpression of HER2 is associated with a worse prognosis for women with breast cancer, namely a greater likelihood of metastasis and relapse and an overall decrease in patient survival. This was really the first report of an oncogenic alteration associated with poor outcome in cancer patients, suggesting a causal relationship to cancer virulence. They concluded that HER2 might play a role in the development and growth of breast cancer. Soon after that observation, that HER2 overexpression occurs frequently in breast cancers, preclinical studies from several investigators showed that tumors that have this aberration are more aggressive than those that do not have it. Around the same time, investigators at Genentech had generated a set of mouse monoclonal antibodies against the protein. One of these, which ultimately became Trastuzumab, was shown in preclinical studies by Dr. Alex Ulrich and Mike Shepard and their colleagues to be particularly potent in reducing the proliferation and survival of HER2-positive breast cancer cell lines. A collaboration then ensued between Genentech and UCLA researchers, which subsequently showed that HER2-specific antibodies could suppress the growth of HER2-positive tumors in mice. Fast forward about 10 years later, and Trastuzumab was FDA approved for the treatment of HER2-positive breast cancer and really completely changed the way we think about HER2-positive breast cancer. Biomedical investigators have since developed substantial understanding of the biology underlying the dependence of cancers on the aberrant HER2 receptor signaling, and these findings have led to the discovery and development of many additional mechanism-based therapies targeting HER2 receptors, resulting in the subsequent 22 years of drug development to target HER2 in breast and other cancers that has improved the outcome for many cancer patients. Oncogenic addiction to HER2, like EGFR, is intimately linked to regulation of its downstream signaling. In cancers that are dependent on HER2, HER2 is the main driver of downstream signaling, particularly via the PI3 kinase AKT pathways and the MAP kinase MEK-ERK pathways. In these cancers, inhibition of HER2 leads to loss of signaling through these pathways, which in turn leads to growth arrest and promotes apoptosis. Heterodimerization of the receptors plays a crucial part in their function. These receptors bind to a wide array of peptide ligands, which results in either homodimerization of the receptors or heterodimerization of the receptors and subsequent downstream signaling cascades. For EGFR, HER3, and HER4, binding of the ligands to their extracellular domains induces the formation of heterooligomers. HER2, in contrast, doesn't bind any of the ERB ligands directly, but it's in a conformation that resembles a ligand-activated state and favors dimerization. Once these are activated, HER2 or EGFR induce transphosphorylation of the dimer partner, which stimulates intracellular pathways such as RAS, RAF, MEK, and ERK, as well as PI3 kinase AKT and mTOR, plus the SRC kinases and STAT transcription factors. These signaling cascades stimulate subsequent cell proliferation, migration, invasion, and survival, all of the hallmarks of cancer. It's been clear since the late 1980s that HER2 is amplified in many breast cancers, but we now know that HER2 amplifications occur in many cancers other than breast cancer. Shown here is a chart showing HER2 amplifications detected by next-generation sequencing in about 60,000 tumors of different types from AACR's Project Genie. You would see a near identical chart if you looked at the 10,000 tumors profiled in the Cancer Genome Atlas or other studies. You can see in these second bar and third bar that amplification of HER2 can be found in about 12% of breast cancers profiled. And this number is likely on the lower side because of the testing approach used. But we also see amplifications in many other tumors at fairly significant rates, such as 14% in esophagogastric tumors or 7% in salivary cancers, and at lower percentages in many other cancers as well, such as colorectal cancer. The identification of amplified HER2 in cancers other than breast cancer led to the hypothesis that this might be an oncogene driving these subsets of cancers as well. And this hypothesis was tested by the development of strategies to target HER2 in cancers other than breast cancer, starting with esophagogastric cancer and now extending to others as well, as we'll hear about later. As more and more tumors were sequenced through TCGA and other studies, it became apparent that an alternate way of activating HER2 was through activating mutations, analogous to what's seen in EGFR and many other oncogenes. These recurrent hotspot mutations are frequently found in the kinase domain and enable HER2 to actively signal without requiring dimerization to a ligand-bound partner. Other activating mutations have been found as well, including mutations in the transmembrane domain that result in homodimerization of HER2 and constitutive downstream signaling. These mutations were initially appreciated in some cancers like breast cancer and lung cancer, although rare, but with increasing sequencing now across multiple cancer types, it's become clear that these mutations exist in multiple cancer types. Shown in green here, alongside the amplifications that we looked at previously, is a chart showing activating or hotspot HER2 mutations detected by next-generation sequencing in the same 60,000 tumors in AACR Project Genie. More mutations in HER2 can be found in these and other tumors that are shown here, but these are the ones we at least know have likely oncogenic activity and are recurrent. And like HER2 amplifications, these mutations have been found to result in increased downstream signaling, in cell proliferation, and in many tumors are dependencies that can be targeted. Importantly, many of these mutations occur without concurrent amplification of HER2, which means that for tumors that have HER2 mutations but not amplifications, there may be modification of targeting strategies that are required. Finally, this graph shows the frequency in an unselected group of patients. Recent studies have shown that the frequency of activating mutations may be even higher in certain resistant and metastatic cancers, such as endocrine-resistant ER-positive metastatic breast cancer. Taken together, we now know that there are multiple types of HER2 multiple types of HER2 alterations in a variety of solid tumors, including amplifications, activating mutations, as well as overexpression without amplification. You can here see a summary of all three alterations across multiple cancer types, and it highlights the importance of looking for and targeting HER2 across these cancers. And we anticipate that many of these instances are dependencies in that cancer, or in some cases resistance mechanisms, all of which are likely targetable through inhibition of HER2 or the HER2 pathway alone or in combination with other therapies. Given the important role for HER2 in many of these tumor types, it's increasingly important to identify these alterations in patients. Listed here is a summary of the ways of approaching testing. For amplification, the standard is in situ hybridization. For expression, immunohistochemistry. And for mutations, sequencing using next-generation sequencing or other approaches. I'll note that sequencing can also detect amplifications as we saw previously, but this is still not approved as a way of finding amplifications. But one important note is that differences in HER2 biology and the heterogeneity between tumor types underscore the importance of using tumor-specific criteria to assess HER2 alterations in clinical practice. The criteria in breast cancer is different than the criteria in esophagus and gastric cancer, which may be different from other cancers. I'll briefly summarize multiple strategies that are used to target HER2 signaling in HER2-dependent cancers, and these will be covered in more detail later. You can see that there are single epitope monoclonal antibodies that either promote receptor internalization and degradation, allow engagement of ADCC, inhibit receptor dimerization. There are drugs that are conjugated to highly cytotoxic agents that can target tumor cells expressing HER2. There are now bispecific antibodies that target both the trastuzumab and the pertuzumab binding sites. And finally, small molecule inhibitors that can directly inhibit the tyrosine kinase domain or downstream members of the signaling cascade. In closing, I also wanted to just say a final few words about HER3. HER3 is not something we've thought about very much and targeted very much. The HER3 heterodimerizes with other EGFR family members. It has weak kinase activity compared to that of its ERB co-receptors. But in a heterodimer, HER3 activation can lead to potent activation of downstream signaling. Mostly we think about targeting HER3, for example, by pertuzumab as a way of preventing dimerization with HER2 in HER2-driven cancers. However, ERB3 itself has been linked to cancer, primarily due to its mechanistic role in promoting signaling from oncogenic HER2 and EGFR. It's also been implicated in resistance to several therapies and is a target for that reason. But more recently, somatic mutations scattered throughout the ERB gene have been identified in multiple cancers, initially in subsets of breast and gastric cancers, and now across many cancers. Many of these have been shown to have oncogenic potential, function in a ligand-independent manner, and require heterodimerization with HER2 for transforming activity. And you can see that in this similar graph from AACR Project Genie, where across multiple cancers you see mutations in HER3 that are activating. So HER3 itself is now being considered as a bona fide target in some cancers. And with that introduction, I'd like to turn it back over to Dr. Hamilton for the next subject.
Thank you so much, Dr. Wagle, for providing us that foundation. Next, we're going to take a little bit of a deeper dive into individual tumor types. And first, I'm going to discuss with you the evolving role of HER2 targeted therapies in breast cancer. So this is a summary slide just showing approved agents over the years. We're all quite familiar with the approval of Trastuzumab in the 90s and subsequent agents listed on this slide. Today, we're going to do a little bit of a deeper dive into some more recent agents. Trastuzumab deruxtecan, Neratinib, as well as Tucatinib. So this is the overall survival seen in the Cleopatra study. Again, with a median overall survival in HER2 positive metastatic breast cancer of about 57 months. This next slide is a diagram that shows the structure of Trastuzumab deruxtecan, our newest antibody drug conjugate targeting HER2 positive tumors onto the stage. You can see the linker here as well as the payload, which I'd like to point out is an exatecan derivative, not our traditional mantanzine that we are frequently familiar with hearing about in antibody drug conjugates. There's also a fixed DAR, drug to antibody ratio of 8:1 here, and these are some of the unique aspects of Trastuzumab deruxtecan as an antibody drug conjugate. An additional interesting factor for trastuzumab deruxtecan really is the profound bystander effect. We think, and we'll discuss a little bit later on, this is one of the reasons that trastuzumab deruxtecan has such great activity, not only in HER2 high, but also HER2 low cancers because of the bystander effect and the ability to target cells that may not express much HER2 at all. So this is the DESTINY-Breast01 trial that trastuzumab deruxtecan was actually approved based off. And quite interesting because it was a single-arm study, but again was approved based on profound efficacy here. Patients were TDM1 refractory, which was the vast majority of the population, 249 patients, with an additional 4 patients that were TDM1 intolerant. You can see here that there's 3 different doses represented: 5.4 mg per kg, 6.4 mg per kg, and 7.4 mg per kg. They initially randomized in the dose-finding stage to the 5.4 as well as the 6.4 dose, but eventually decided on a dose of 5.4 mg per kg based on tolerability as well as efficacy here. I'd also like to highlight that in this population that I'm going to show you, that majority of patients, over 65%, had received prior pertuzumab. So this is the waterfall plot, and again, you can really see profound activity. On the y-axis, you see the best change from baseline, and each individual bar represents an individual patient. So the confirmed overall response rate, again, was 60.9% with 11 complete responses. And again, a majority of patients that did not get a response still having some shrinkage or stable disease. Here you can see the objective response rate by subgroup. Again, prior pertuzumab was over 60%. Hormone receptor was relatively equally split, about 57% positive. Brain metastases, you can see indicated here as well. Performance status, all ECOG 0 or 1. These are the curves for progression-free survival with a median PFS of 16.4 months. I think this is a really telling slide. We have not seen a median progression-free survival this long in the metastatic pre-treated patients in HER2 positive disease. And so really quite impressive considering that the median number of priors among the patients in DESTINY-Breast01 was 6. So quite heavily pretreated population, and not only did they get a great response rate, this was also durable in duration. And overall survival here you can see was not reached. So based on this, on December the 20th of 2019, the FDA granted accelerated approval to trastuzumab deruxtecan for patients with HER2 positive breast cancer that was metastatic and who received 2 or more prior anti-HER2 based regimens in the metastatic setting. So looking ahead, there are additional trials with trastuzumab deruxtecan and key indications. We have DESTINY-Breast02, which is trastuzumab deruxtecan versus standard of care after TDM1. So again, a confirmatory population to the trial I just presented. We have DESTINY-Breast03, which is trastuzumab deruxtecan versus TDM1, so a so-called second-line metastatic trial. And then finally, DESTINY-Breast04, which is trastuzumab deruxtecan versus chemotherapy in those patients that are HER2 low, so a kind of non-traditional population, but again, based on the efficacy we've seen here in the low population. So briefly, I just want to touch on Neratinib. This is another approved drug we have that's a tyrosine kinase inhibitor targeting HER2. It's a pan-HER2 blocker. It binds both HER1, HER2, and HER4. It's demonstrated activity in both early stage as well as metastatic setting and has been FDA approved to extend adjuvant treatment of patients with early stage HER2 positive breast cancer, and as well as having activity in HER2 positive breast cancer in the metastatic arena, as well as for patients that are struggling with CNS metastases. This is a schematic of the phase 3 NALA trial. This tested Neratinib and capecitabine versus capecitabine with lapatinib instead. The primary endpoints were progression-free survival as well as overall survival. We saw Neratinib and capecitabine significantly improve progression-free survival versus lapatinib. We also saw overall survival here trend towards Neratinib capecitabine, but this was not statistically significant with a p-value of 0.21. The safety profile of Neratinib is consistent with other tyrosine kinase inhibitors, some rash, some diarrhea, fatigue as well. Here's a schematic from the NALA trial for the progression-free survival. You can see a benefit here of about 2.2 months, from about 6.5 months up to 8.5 months for the addition of Neratinib instead of Lapatinib to a capecitabine backbone. This is also time to intervention for CNS metastases. You can see that this is relatively the same for Neratinib and capecitabine versus versus Lapatinib and capecitabine. So on February the 25th, 2020, the FDA approved Neratinib in combination with capecitabine for patients with HER2 positive metastatic breast cancer who again have received at least 2 prior regimens in the metastatic setting. You can also see here on this slide highlighted that Neratinib also has activity in some patients with HER2 mutated breast cancer. As Dr. Wagle eloquently explained to us, these aren't amplifications, but instead mutations. We can see the objective response of 17 patients, 9 patients with responses translates to 53%. And we can also see the clinical benefit here with additional patients having stable disease for greater than 24 weeks. The median progression-free survival for those patients with HER2 mutated breast cancer with Neratinib was 9.8 months. And finally, I want to transition to a new HER2 specific tyrosine kinase inhibitor that's been recently approved, Tucatinib. This again is orally bioavailable as we would expect for a tyrosine kinase inhibitor. But what's unique about this compound is that it's selective for HER2 over HER1 or EGFR. What this translates to is a little bit better efficacy as we don't see rash and diarrhea that can plague patients with Lapatinib and Neratinib. This is the Her2 Climb study design. 612 patients were randomized in a 2-to-1 fashion, either to capecitabine Trastuzumab with Tucatinib or capecitabine Trastuzumab with placebo. These patients have already seen Trastuzumab, Pertuzumab, and T-DM1, and so this is kind of a traditionally third-line regimen, third-line space here that we're looking at. And this is the overall survival in the entire study population. We can see 17.4 months up to 21.9 months, and you can also see some landmark analyses drawn for you here on the slide at 12 months and at 24 months. At 24 months, 27% of patients were progression-free with capecitabine and Trastuzumab alone, and 45% were progression-free with the addition of Tucatinib. We can see across different factors that really the benefit looks like it is for everyone, regardless of hormone receptor positive status being positive or negative, age, younger or older, or region of the world these patients were treated in. This is a slide outlining what we know about the efficacy of HER2-targeted therapies in patients with brain metastases. We have the evidence in Cleopatra and Nefertiti of delaying CNS progression. In Nala, we can also delay time to CNS intervention. In Amelia with T-DM1, there was an overall survival benefit in patients that had CNS disease. And in Phoenix with Pyrotinib, we've also seen a delay in CNS progression. Here in the Her2 Climb study with Tucatinib, we see progression-free survival with patients with brain metastases. The hazard ratio here was 0.48 and was statistically significant. I think a very telling statistic on this slide is 0% of patients were progression-free of those patients that had brain metastases on the Her2 Climb study at a year if they were not receiving Tucatinib. For those patients that were receiving Tucatinib, a quarter of them were progression-free. And again, and this is in the subset, the 48% of patients on the Her2 Climb trial that entered with known brain metastases, the benefit per population. And again, this looks very similar to the all-comer plot that we saw earlier. This is the Her2 Climb exploratory efficacy in patients with brain metastases. This is the CNS progression-free survival benefit. Again, 4.1 months up to 9.5 months with the addition of Tucatinib. And this is the overall survival curve. Again, overall survival 11.6 months up to 20.7 months in that 48% of patients on the Her2 Climb trial that had brain metastases at baseline. I'd also like to call your attention to a unique aspect of this trial. Her2 Climb really enrolled patients with 3 categories of brain metastases. One is what we expect to see on trials, those patients with treated and stable brain metastases. Those were the stable patients. And then there were two additional subsets of patients that were grouped into an active brain metastases. And those were patients that had untreated asymptomatic brain metastases or who had treated and subsequently progressive brain metastases. And so this was really a unique aspect of the trial, as this was a very high-risk population and a population of patients with brain metastases that are not traditionally allowed on clinical trials. Here we see CNS progression-free survival in the patients with stable brain metastases, 5.6 months up to 13.9 months, again, statistically significant. On our subset for overall survival for patients with stable brain metastases, again, we're subsetting the trial quite significantly here into smaller spots, but with 13.6 months up to 15.7 months, and this was not statistically significant. On April the 17th, the FDA approved tucatinib in combination with capecitabine and trastuzumab for patients with metastatic HER2 positive breast cancer who have received at least one prior HER2-based regimen in the metastatic setting. And so this is a little bit different than the traditional kind of third-line population that enrolled in HER2 CLIMB. And on my last slide, I'd just like to show you current and emerging HER2 as well as HER3 targeted therapies. We're going to hear a little bit more about HER3 later. We can see that we have novel antibody drug conjugates coming, antibodies, which you can think of as trastuzumab or pertuzumab, bispecific antibodies that block not only one spot, but may either block both HER2 and HER3 or various targets here. We have novel tyrosine kinase inhibitors, and then in the arena of HER3, we also have bispecific antibodies as well as antibody drug conjugates. So next, I'd like to turn over to Dr. Janjigian, who is going to talk to us about gastroesophageal and colorectal cancer and HER2 as a target.
Thank you, Dr. Hamilton, for that introduction. I'm a medical oncologist, and I treat a variety of GI tumors, including GE junction and colorectal cancer, and I'd like to review the developments in HER2 as a treatment strategy in these tumors. Trastuzumab was first FDA approved for treatment of metastatic, previously untreated, HER2-positive GE junction and gastric cancer in 2009. Since then, besides trastuzumab, we've reached many roadblocks, and unlike breast cancer in HER2-positive space in GI tumors, there's currently no FDA-approved indication or treatment for other agents. This is the summary of Kaplan-Meier curves for the first-line pertuzumab plus trastuzumab in chemotherapy study in HER2-positive metastatic esophagogastric cancer and the overall survival for the intent-to-treat population. And although you can see the curves here separate in the middle, ultimately they come together for survival. And there was no, this trial did not meet its primary endpoint overall survival benefit, although there was a trend toward PFS and response rate improvement. The addition of pertuzumab in first-line setting did not overall beat the standard of chemotherapy and trastuzumab for survival. There are many caveats, and in GI tumors, particularly addition of pertuzumab to fluoropyrimidine-based chemotherapy, which is what we typically use in our first-line setting, unlike breast cancer, may have contributed to diarrhea and overall chemotherapy delivery intolerance. But nonetheless, pertuzumab is not currently used in first-line setting. At ASCO 2020, you saw the data recently presented for preoperative FLOT pembrolizumab trastuzumab study that showed a dramatic path CR rate of 25%, again giving us a pause and suggesting that pertuzumab or more intensified HER2 therapy may have a role in gastric cancer. And right now, we need to do additional studies to further characterize this involvement. The field has moved on in gastric cancer, where anti-PD-1 therapy has really been shown to be effective in select patients beyond MSI-high tumors. And this is a phase 2 study conducted at Memorial Sloan Kettering, showing that combination of pembrolizumab with trastuzumab and chemotherapy demonstrated overall response rate of 91%, with 100% of the patients having disease control rate and some decrease in tumor measurement. With the small cohort of 37 patients, the study was recently published demonstrating progression-free survival rate of 70% at 6 months, with median overall survival rate of 27 months, which compares favorably to what we would typically expect in the setting with chemotherapy and trastuzumab alone, where the overall survival rate typically is less than a year, and the response rate is 47%. So this study is now being explored in phase 3 study with KEYNOTE-811 study, and hopefully will change the practice for first-line metastatic esophagogastric cancer. What we learn in gastric cancer and esophageal cancer is that co-occurring alterations and heterogeneity in HER2 expression really drives a lot of the resistance. We find that RAS is more activated, as you can see on this oncoprint of sequencing, and circulating tumor DNA and level of HER2 amplification on circulating tumor DNA may help us enrich for the population of patients who would benefit and have a longer duration in progression-free survival and overall survival in first-line HER2 study, as you see on this Kaplan-Meier curve. Patients with baseline ERBB2 amplification and circulating tumor DNA tend to benefit from HER2-directed therapy for longer periods of time. And also, if you have already co-occurring KRAS or RAS amplification or a mutation in the tumor and circulating tumor DNA, the likelihood that you are going to progress on first-line therapy is much higher. And again, this should be an important stratification factor for future biomarker work and clinical trial development. What we also note that ctDNA, circulating tumor DNA, matched with tumor assessment can help us pick up progression of disease, sometimes weeks, if not months, prior to radiographic progression, and maybe an important biomarker to help guide second-line therapies and patient selection for treatment beyond trastuzumab progression. Unfortunately, up to this point, unlike breast cancer, none of the trials so far have shown that there's any benefit to continuing HER2-directed therapy or trastuzumab in particular beyond progression. The TDM1, which is the ADC that has a microtubule crosslinker or taxane-like crosslinker, failed in comparison to paclitaxel alone in second-line setting Gatsby study. So it did not show any improvement for TDM1 over paclitaxel without any HER2-directed therapy. And TACT study, which is a phase 2 study looking at using a trastuzumab beyond progression in combination with paclitaxel versus paclitaxel alone, also failed to show any benefit in HER2-positive gastric cancer. One caveat in gastric cancer is historically biopsies of progressing tumors has not been mandated in clinical trials, and getting archival sample from a surgical sample from a year or two before initiation of second-line therapy certainly is not appropriate to learn about the current driver in the tumor biology for patients at progression. This is a small set of samples. As you can see, only 16 post-progression samples were available in the second-line trastuzumab beyond progression study, the TACT study, and the majority of the tumors that were examined were actually found to be HER2 negative. In a more prospective fashion, looking at HER2-directed alterations and matched pre and post samples, both on standard clinical assessments such as IHC and FISH, but also on deeper sequencing with NGS, we find that loss of HER2 or gain of secondary amplifications and alterations in parallel escape pathways such as KRAS, MET, PI3 kinase occurs in up to 30% of the tumors. This is a data set we published a few years ago in Cancer Discovery, again suggesting both a clinical assessment with IHC and FISH, but also NGS may be very critical to our patients to understand mechanisms of resistance. And certainly with the advent of routine circulating tumor DNA sequencing, it will help us guide therapies in first-line and second-line setting. This is a trial of margetuximab and pembrolizumab that showed also promising results, once again showing that there is quite a bit of both temporal, so pre and post therapy, and spatial heterogeneity between different sites of disease and sites of metastasis for HER2 expression, and MYC and other oncogenes can be followed and can be assessed through ctDNA to predict mechanisms of resistance to both HER2 antibodies, but also TKIs such as Lapatinib, which, by the way, also is not routinely used in gastric cancer because of several negative studies. So now in the 21st century, we're catching up, and everyone's routinely biopsying patients for second-line therapy, at least in the setting of a clinical trial. And kudos to the Daiichi group designing this DS-80201 study in the second-line setting, currently accruing patients in the US and Europe, where a second biopsy is mandated before trial enrollment to help enrich for HER2 and maximize benefit to our patients in clinical trials. Destiny Gastric 01 study was just published in New England Journal of Medicine and presented at ASCO 2020. This is a third-line study accruing patients in Japan and Korea, looking at DS-80201, and Dr. Hamilton eloquently summarized the mechanism of action of this drug, and so it's important to know that the chemotherapy payload is quite high in with this agent, and also its payload is similar to irinotecan, so different from the taxane-based ADCs. And irinotecan has a very long history of efficacy in GI malignancies, and I think is an important drug for several cancer types, in colorectal and gastric included. And so gastric cancer, Destiny Child has really showed a dramatic benefit in heavily pretreated patient population with median cycles of prior systemic therapy of 3 to 4. And compared to chemotherapy with docetaxel or irinotecan, it showed clinically and statistically significant benefit with confirmed overall response rate of 42%, which is unprecedented in this setting, where we would typically see responses of 8 to 11%, depending on which clinical trial you look at. And for the first time ever, so really groundbreaking, finally showing benefit for using HER2-directed therapy in later lines of therapy beyond Trastuzumab. So Destiny Gastric 01 again resurrected the field of HER2-directed therapies in second and third line and beyond, and looking at the overall survival. This subset of patients certainly is very unique. In gastric cancer is quite heterogeneous, and in Asian population, the survival rates in general is more favorable than the West. So this data needs to be confirmed in the West, but really these survival rates are unprecedented, and certainly the response rate is quite dramatic. One thing to note is that the dosing of DS-80201 in gastric cancer is higher than breast cancer because of the different tumor burden and pharmacokinetics of this disease. And despite higher dosing, the rate of IPL, or the pulmonary toxicity in this trial, was relatively low, and there were no grade 5 events, again, which is hopeful for our patients as we develop this drug in earlier lines of therapy in gastric and colorectal cancer in the US. So based on Gastric 01 study, the FDA actually granted a priority review of this drug, and it will hopefully be available for third-line setting in the US, even prior to completion of the second-line study that is currently ongoing. In colorectal cancer, so just to give you a sense for the numbers, gastric cancer is a global disease with over 1 million cases worldwide. Up to 20 to 30% of esophagogastric tumors are HER2 positive. Those are more commonly seen in the GE junction and the proximal stomach. In the US, gastric cancer is rare. Colorectal cancer is one of the big three. So there's a lot of colon cancer in the US, but a smaller proportion of those tumors are HER2-driven, Depending on what data set you look like 5% or so of colorectal tumors, or maybe less, are HER2-driven. And so it's important it's a bigger ask, but it's important to still treat and test routinely for HER2 in colorectal cancer, where NGS platforms may actually lend themselves for that. It's important for colorectal cancer to know both KRAS status and HER2 before you move forward with HER2-directed therapies. So combination strategies in GI tumors is really the way to go, and both Trastuzumab and Neratinib and Trastuzumab, Pertuzumab have shown a promising response rate, with overall response rate of 40% seen in combination with Pertuzumab. It's important to put this in context where targeted agents in colorectal cancer historically have not worked. So for something to work and without a chemotherapy backbone, with just biologic agents alone, is really a paradigm shift in GI tumors, and is an exciting area of research and drug development. As you know, in colorectal cancer, beyond BRAF and MSI high, which are a small percent of patients, there's currently very few biomarker-directed strategies. It's important for RAS mutant tumors not to direct the HER2-directed therapies. RAS is an escape mechanism for ERBB2 signaling, and study after study is now showing that both with EGFR, which is HER1, and HER2 now, ERBB2 pathway targeting is not effective in RAS mutant tumors. One of the hot topics at ASCO this year was, how do we target RAS? And unlike lung cancer, unfortunately, in colorectal cancer, the RAS targeting is still a big challenge and a research development strategy. This is a clinical trial summary for HER2-directed agents. And as you can see here, very small numbers, but proof of principle that we see time after time. The Tucatinib study, Tucatinib is a highly selected HER2 inhibitor, and therefore from the perspective of toxicity is quite appealing. And also the crossing the blood-brain barrier is also very exciting in our disease. We notice that although in colon cancer and in gastric cancer, brain mets are rare, but now that we're changing the biology of the disease, more and more of our patients live longer and then develop brain mets. So to have an agent that potentially can target those tumors will be very important. And once again, Destiny's CRC trial, the colorectal trial, showing exciting results for this agent in colorectal cancer in very heavily pretreated patient population. As you can see here, in greater than 2 prior lines of therapy. So these patients who progressed on both FOLFOX and generally FOLFIRI. And so to have an ADC with irinotecan-like payload work this way is quite exciting, and again highlights the importance of HER2 in this disease. What I wanted to also expand and highlight to what Dr. Hamilton mentioned on the off-target effect of DS-80201. And in gastric cancer and colorectal cancer, because of the secretory nature of the epithelium, we do see quite a bit of heterogeneity in HER2 expression, and where perhaps only 5% or 10% of the HER2 of the cancer cells overexpress HER2. So to have this bystander effect on the rest of the tumor is quite critical in our disease, and makes it very exciting for us to develop these new class of ADCs with a bystander effect in our tumors. Similar to the gastric study, again, 45% overall confirmed response rate in the colorectal Destiny study, and this was a very exciting year for this agent at ASCO. Looking across different cohorts in this forest plot, prior HER2 treatment is not patients with progression on prior trastuzumab-based therapy seem to have benefited as well. Thank you for this opportunity, and I'll hand over the rest of the presentation to Dr. Patel to talk about lung cancer.
Great, thank you so much. And so I'm here to discuss the emerging roles of HER2-targeted therapies in non-small cell lung cancer. And so one of the key aspects to focus on, especially in clinics in which you treat multiple types of patients, is to make sure to get the right biomarker test for the right disease for the right patient. And so we've talked about HER2 overexpression in breast cancer and gastric cancer, HER2 amplification. What I'm going to be talking about is HER2 mutations in particular. And these are driver mutations that can occur in non-small cell lung cancer, for which traditionally these patients have been treated with chemotherapy. More recently, patients have been treated with immunotherapy, but I'd like to give the point that many of the agents that are utilized in HER2-targeted non-small cell lung cancer can cause pneumonitis, which is inflammation of the lung. And so typically we resort to immunotherapy as the last line of therapy for this subgroup of patients as to minimize their risk of getting this potential side effect. We have multiple targeted therapies, and I think this is an area of active research and excitement for our patients, as these have the tendency to work better in the brain, which is an issue for this type of cancer. And so we see with targeted therapies, historically drugs that are FDA approved, like afatinib and dacomitinib in non-small cell lung cancer, other agents such as neratinib, osimertinib, poziotinib, pyrotinib, mobocertinib, and tarloxitinib are all targeted therapy agents that have demonstrated activity in clinical trials against the HER2 mutation. We also have monoclonal antibodies and antibody drug conjugates such as trastuzumab, pertuzumab, TDM1, and trastuzumab deruxtecan, which we've been discussing, which I'll refer to as TDX for the remainder of the presentation, and in combinations therein. But fundamentally, when you're treating a patient with advanced non-small cell lung cancer, this is something that will only be found by DNA sequencing, by next-generation sequencing. This is not something at the current time that can be discovered based on an immunohistochemistry protein-based test, and amplifications, we're not yet sure how best to treat these when found in advanced non-small cell lung cancer, but there have been negative studies of HER2 overexpressed by IHC trastuzumab, and so the focus of this is based on exon 20 insertions detected by DNA. And so to highlight this point even further, HER2 mutations and amplifications are distinct targets. It's not enough to test for HER2. We have to do the appropriate test for the given disease we're studying. And while HER2 is overexpressed or amplified in a significant fraction of lung adenocarcinomas, this has undefined prognostic significance. And in fact, there was a negative study of trastuzumab in HER2 overexpressed cancers. However, for those patients with HER2 mutations, this in fact represents an actionable mutation within non-small cell lung cancer, and in particular, this mutation tends to occur in the exon 20 kinase domain, which I'll be discussing shortly. And so to go back to Dr. Waglay's excellent discussion about HER2 biology, I'd like to focus here on small molecule inhibitors inside D. When we're looking at the HER2 protein, there's an extracellular domain, and this is where antibodies bind, such as trastuzumab, TDM1, TDX. But within the kinase domain itself, the part of the protein that's within the cell, this is where small molecule inhibitors work. This is in fact where the mutation happens. This is the scene of the crime in non-small cell lung cancer. We get small in-frame deletions of exon 20 or activating mutations. And so it makes sense that drugs that target this unique biology, which is different than what we most commonly see in breast cancer and gastric cancer in terms of our earlier discussion, this is actually where we need to intervene on for the benefit of our patients within the cell itself, or at least if we're going to act extracellularly, intervene on the mutant activity of these exon 20 insertions, in-frame deletions, or kinase domain mutations. And so when we see these multiple agents that have been studied, whether we're talking about small molecule inhibitors, we've historically had lower response rates on the order of about 10% with afatinib and dacomitinib. Some of the next generation agents, poziotinib and pyrotinib, have had about a 50% response rate, although the progression-free survival is approximately 6 months or less. But where we really started to see some novel activity is with TDM1 and TDX in particular, in which the response rates are over 50%, but especially with TDX, over a progression-free survival of over a year. And though this antibody acts extracellularly, what it does is it depletes HER2. And so the best way to explain this is while TDM1 may be a precision-guided bunker buster, TDX is a precision-guided cluster bomb. It in fact has this bystander effect we've discussed earlier. And not only does it destroy the TDM1 in the active cell, it actually, for the cells that are not directly bound by the drug, it actually destroys the HER2 most likely as well in those cells that express it, thus leading to decreased kinase domain activity from the overall efficacy of this agent. And so the key aspect in non-small cell lung cancer is still intervened upon, but it's particularly for patients with HER2 mutations. We do not yet have the data in this cohort for HER2 amplified patients. So going back to TDM1, which is a very effective agent in breast cancer, if we look at this in patients with HER2 mutant, right, most commonly an exon 20 aberration non-small cell lung cancer, we see an overall response rate about 44%, with some durability of this response in a subgroup of patients. Poziotinib, which is a small molecule inhibitor that binds the kinase domain, also has activity in this subgroup of patients with HER2 mutant non-small cell lung cancer. And we see here in the waterfall plot a variety of different mutations can lead to activity of this agent amongst the HER2 mutated patients. However, the progression-free survival tends to be on the order of less than 6 months. Mobocertinib, or TAK-788, has also been investigated in HER2 mutant non-small cell lung cancer. And we see here, as mentioned earlier by Dr. Wagle, HER2 is part of the EGFR superfamily. We actually see activity for this agent, not only for HER2 exon 20 mutations, but EGFR exon 20 insertion mutations as well. Both of these are present in about 2 to 3% of non-small cell lung cancer adenocarcinomas. And we see here a response rate anywhere from 20 to 40%, including a complete response in a patient with an EGFR exon 20 insertion. And so one of the key points to take is that we have to test these patients to discover that they have one of these aberrations so that we can best intervene with one of these targeted therapies or antibody drug conjugates. Pyrotinib, which has been studied as well in HER2 mutant non-small cell lung cancer, shows robust shrinkage in a subset of patients with HER2 mutated non-small cell lung cancer. We see here both in the waterfall plot and especially by mutation type, we tend to see activity predominantly in those patients with insertions. The DESTINY-Lung01 trial studied TDX, Trastuzumab deruxtecan, in a cohort of patients that are HER2 expressing. In cohort 1, we do not have the results of this data available, and in HER2 mutated non-small cell lung cancer. This is the cohort of current interest in the data that I'll be presenting. And as I mentioned, the majority of these mutations occur in exon 20, and they can currently be detected by next-generation sequencing methods, which for many of our patients with metastatic non-small cell lung cancer will opt for a next-generation approach to test for EGFR, ALK, ROS1, and a variety of other driver mutations. In HER2 mutations can also be detected, especially exon 20 insertions, by similar next-generation sequencing technology. I'd like to point out that the dose of TDX here is 6.4 milligrams per kilogram every 3 weeks. And one of the toxicities that was mentioned earlier in terms of interstitial lung disease is particular concern for our patients with non-small cell lung cancer, in that these patients often have underlying lung disease and may have relatively poor pulmonary reserve. The second point I'd like to make is many of these patients may have been pretreated with immunotherapy, which at least in other contexts can lead to a heightened risk of pulmonary toxicity. And so when treating a lung cancer patient with any of the HER2-directed agents, in particular an agent as potent as TDX, it's important to assess lung function and intervene early on pneumonitis, which is an intervention historically with any of the agents in the class best managed with steroids. And so we see the efficacy here, a 62% objective response rate, 2.4% complete response rate, almost 2/3 of patients getting a partial response. This really is a phenomenal result. And from ASCO 2020, I think one of the most impressive results I saw in the non-small cell lung cancer space. Over 90% of patients had disease control and a progression-free survival median of over 14 months. This really is phenomenal efficacy for historically a disease that's very aggressive and for which therapies have frequently been more toxic with shorter progression-free survival and benefit. And so really this represents a high watermark for the treatment of this disease for HER2 mutant non-small cell lung cancer to date. We see here on the swimmer's plot in the top right that many of these responses are durable in a subset of patients. And the waterfall plot in the bottom left, you can see the majority of patients had a response or shrinkage. In fact, not a single patient had growth in the cohort of 39 patients with HER2 mutated non-small cell lung cancer. So an extremely active agent, but we won't be able to utilize this agent once it's hopefully FDA approved if we don't test patients appropriately with next generation sequencing with non-small cell lung cancer patients. The safety signal overall, this was very well tolerated. Many of the other agents in this class have diarrhea and skin toxicity issues. This drug did not have that be the majority of patients. In fact, tolerate this drug very well. The main point to make is there is a low level of interstitial lung disease in this subgroup, grade 2. About 12% of patients develop grade 2 interstitial lung disease. And so for patients with lung cancer, something we very much want to pay attention to, especially if this is a patient that has poor underlying lung function or may have had antecedent immunotherapy, where at least with other drugs that target this class, there is a heightened risk of pneumonitis. And so something to be aware of, not a barrier to utilize this highly effective agent, but something to counsel our patients on so we can intervene once this drug becomes hopefully more widely available based on this efficacy. And so with that, I'd like to turn the discussion over to Dr. Hamilton for the next part of this discussion.
Thank you, Dr. Janjigian and Dr. Patel, for taking us through GI cancers and lung cancers. At this point, let's stop and have a bit of a conversation on optimizing HER2 testing and thus integrating HER2 targeted therapies. So, what are some of the key issues and challenges related to HER2 testing and management of patients with HER2 positive cancers? And I think we've heard, across the board that there are some differences between GI malignancies and lung cancer and breast cancer. Maybe I'll pose the first question to Dr. Wagle to help us discuss this. What do you see as the difference between these types? It seems like perhaps with GI cancers, there may be a little bit more tumor heterogeneity, and lung cancers, mutations may be a little bit more important. What do you make of this?
It's a great place to start, and I think that's really the crux of why we can't just say we're going to target HER2 the same in every cancer. And there are a few different elements to that. One is, as we saw in all the presentations, there are different types of HER2 alterations in different cancers, and amplifications are not the same as overexpression, and those are not the same as mutation. But then it gets even more complicated because within each of those categories, in a given tumor type, there may be differences that are more subtle, a high amplification versus a low amplification, or a mutation in the kinase domain versus a mutation out of the kinase domain. And so those may have implications as well. And then, as you point out, the biology will be different. And so in breast cancer, a high amplification may be very clearly a driver and more homogeneous, whereas in gastric cancer, I think it's clear that heterogeneity and lack of HER2 being a sole driver is probably more the rule. So that's the third. And then I would say a fourth is that there are potentially other targets to think about. And so in some cases, monotherapy against HER2 may be a really good choice, but in others, as we saw in colon cancer, there may be second drivers, there may be modifiers like KRAS, or the HER2 may be a resistance mutation that would require still targeting the backbone dependency. And so all of these factors make thinking about HER2 testing and targeting really complex.
Great, thank you. I might pose the next question to Dr. Janjigian. You talked about the negative trial with Trastuzumab, the Jacob trial, and that kind of stands out in contrast to me for breast cancer. Yet you're clearly seeing great activity with Trastuzumab deruxtecan and ADC. Do you think it's a biology difference, a mechanism of resistance difference, or maybe tumor heterogeneity that's kind of making it seem that for GI cancers at least, that antibody drug conjugates may be better than antibodies alone?
That's a great question. Thanks for bringing it up. We were all heartbroken when Trastuzumab study in Jacob was negative. Some of it is complex, and as a trialist, you'll understand a lot of it comes down to trial design and patient selection, and what you can do in a smaller, perhaps investigator-initiated phase 2 study, it's harder to translate it to a large phase 3 study. And the caveat also is that the bottom line is in first-line setting in gastric cancer, chemotherapy and trastuzumab work, and addition of pertuzumab, although was somewhat effective, just did not meet the cutoff and the primary endpoint criteria. So some of it, I would say, is probably patient selection, but also the trial design that was the caveat. So in first-line setting, we clearly know that HER2-directed agents work. They may not work as well as they do in breast cancer, and because co-occurring alterations and RTK activation is so much more prominent in gastric cancer than in breast cancer. The idea with the why TDX worked in third line in gastric cancer as opposed to other ADCs is probably the drug delivery and the bystander effect. That's becoming more clear. The third line study, interestingly, actually did not enrich by confirming HER2 population. So they went back based on the archival samples. So you could expect that up to a third of those patients were actually probably HER2 negative. And those patients, and overall response rate was still quite impressive. So it's probably the payload that matters, and irinotecan-based therapies really work well in GI tumors, but also the bystander effect.
Great, thank you. And we'll let Dr. Patel wrap up this section for us. Are any parting thoughts on differences of testing or classes of agents that we think are going to be more effective in one tumor type compared to the other?
Yeah, I think, we talk a lot about precision medicine, and I think the advent of HER2 testing really, which is an aberration we see across tumor types, is a testament to that, but it's not enough to just find HER2. It turns out it's even more nuanced than that, and whether it's an amplification at the DNA level, meaning multiple copies are made, whether it's an actual mutation in the kinase domain that leads to constitutive activation, basically the light switch being flipped on and not being able to be turned off, or whether it's protein overexpression, which has multiple mechanisms. It depends on the disease you're treating, and I think one of the nice things about this discussion and getting to talk with everyone are those nuances. In breast cancer, if you're a busy community oncologist, you're spending most of your time probably doing HER2 testing in breast cancer, and you're looking at this based on IHC and reflexive FISH. Meanwhile, you may not be seeing as much gastric and non-small cell lung cancer. However, in those settings, it's important to get the right testing. And so part of precision oncology is getting the right test to the right patient so they can get the right drug. And I think one of the nuances is that, for example, in non-small cell lung cancer, that best test is next generation sequencing. For breast cancer and gastric cancer, as well as colorectal cancer, it's IHC and FISH-based approaches may be relevant. And then in colorectal cancer, as Dr. Janjingian really kind of honed on, there are multiple potential treatment options that may develop. And so I think getting the right test for the right patient is key. And if you don't know what to do with the test when you get it back for the patient, going to your referring center, having them get that second opinion so we can figure out what the best next approach for those patients is, I think is key. And I think the other theme you're seeing is we have small molecule inhibitors and we have antibodies and antibody drug conjugates. And the best strategy for any given patient may depend on their particular mutation. And so molecular tumor boards can be very helpful in discerning complex molecular information. But I think it's key in getting the best outcome for our patients because the data we've seen across different histologies has been very impressive when we match the right drug to the right patient.
Absolutely. Thanks so much. So I'm going to move into our final section before we take live questions from the audience. And this is really about new research directions within HER2 and other emerging targets. And so I'm going to turn this over to Dr. Wagle, really to talk about HER2 low, HER2 mutations, and then as well as Dr. Patel to talk about HER3 and TROP2 as targets as well. Dr. Wagle?
Great, thanks. I think we've heard a lot about some of the new directions already, and certainly there are many exciting directions in HER2 testing and therapeutic targeting to look forward to. One of them that Dr. Hamilton, you alluded to in your talk is the idea of HER2 low tumors. And so we heard about TDX and its ability to serve as a cluster bomb, to use Dr. Patel's analogy, which means that you can use the expression of HER2 to as a targeting, as a location targeting, but not necessarily targeting a dependency in HER2. And that opens up the possibility that for tumor cells, for tumors where a subset of cells are expressing HER2, even if that HER2 is not the driving oncogene on which that tumor depends to grow, it might be sufficient to have the drug honed to that area and use that potent chemotherapy to kill both the cells expressing HER2 as well as nearby cells. And so that's being tested now, this idea of targeting HER2 low, in one of the Destiny trials, as Dr. Hamilton showed in her slide, to look at HER2 low expressing breast cancer. So this is the subset of breast cancers that either don't have amplification measured by FISH. They're either IHC positive and FISH negative, or IHC low, but not zero, to see if this drug will be effective there. And that's really important because that is a group of cancers in which we don't have a clear targeted therapy right now. So I think that's a particularly exciting direction. Another topic that we've touched upon goes back to HER2 mutations. I think Dr. Patel pointed out that amplifications are very important in some cancers, but may not be as important in other cancers, such as in non-small cell lung cancer. But we clearly see, as I showed in my talk, activating mutations across multiple cancer types. And it seems likely, and the evidence that we've seen has supported this, that when you see an activating mutation in HER2 in multiple cancers, that activating mutation is important and therefore likely targetable. And so the question is, what do we do when we see these activating mutations in multiple cancer types, and why are they arising? And I think for acquired HER2 mutations in breast cancer, for HER2 mutations in breast cancer, we have recently learned that these mutations can actually be acquired as a resistance mechanism. So in patients with ER-positive metastatic breast cancer that have developed resistance to endocrine therapy, those patients can develop new HER2 mutations that weren't present in their initial tumor. And in vitro experiments have shown that these mutations actually cause resistance to the aromatase inhibitors or the tamoxifen or the fulvestrant that those patients got previously. So this brings up yet another reason why it's important to test, as Dr. Janjigian said, to test patients with their most recent tumors, because looking at these patients, if you tested their original tumor, you might not see a HER2 mutation, but if you test their most recent tumor, their metastatic biopsy, you can find these acquired HER2 mutations, which are important to target, both to target the tumor, but also to overcome the resistance. I would say that the other important point here is that targeting HER2 mutations in this setting, when they cause resistance, may not be sufficient. You may need to target the HER2 mutations as well as the original thing you would target in this cancer. For example, in breast cancers that are ER positive with acquired HER2 mutations, it's been shown that the combination of a HER2 small molecule, HER2 targeting small molecule, as well as endocrine therapy is important for maximum efficacy. And I think we're going to see that pattern play out more and more in lung cancer, and I'd love to hear Dr. Patel's thoughts on that, but also in other cancers as well.
No, absolutely. I think the story is very clear that HER2 is a driving mutation. If we're trying to chop down the cancer tree, for lack of a better word, it is the trunk. But there are lots of branches we need to simultaneously target, and maintaining targeted pressure on other pathways that lead to escape, whether it be downstream dimerization with HER3, for example, EGFR. I think these are some of the important topics. I think the other point, Dr. Wagle, and you brought this up very clearly, is that while immunohistochemistry overexpression is something you do on the tissue and you need to have the freshest sample possible, when you're looking for amplifications and you're looking for mutations, liquid biopsy or cell-free DNA can be a reasonable approach for those patients. So where, they may have brain mets that are very hard to get to, or bone metastases in which DNA sequencing may be suboptimal in tissue, that when we're looking for mutations, we're looking for amplifications, the ability now to do it in a tube of blood by cell-free DNA really is transformative, and it can help us identify resistance mechanisms that we can currently target. And so I think This really is a key point. I think the other point we discussed is that their EGFR it's a crime family, right? You have EGFR, you have HER2, you have HER3, you have HER4. When they get dysregulated, they lead to cancer. And so one of the areas we're looking at, we see here, is how neuregulin can interface with HER2 and HER3. And we see this downstream signaling here in the bottom right, which leads to all these changes that lead to transformation, that leads to cancer growth. So anything we can do to intervene on this axis, starting at neuregulin or herregulin, all the way down to how it leads to metastatic potential, I think is really key. And so one way we've looked at that is other antibody drug conjugates, such as U3-1402, which is a novel anti-HER3 ADC. And Dr. Wagley, I'd love to hear your thoughts about this relative to other agents in the field.
I think targeting HER3, as you described, has a lot of potential given its role both in the heterodimerization and signaling, but also as its own bona fide target because of the increased presence of mutations that we see in HER3. And again, like with HER2 mutations, I anticipate that HER3 mutations as a mechanism of resistance might start to increase over time.
No, great points. And so we see here, HER3 is something that's found in multiple tumor types: breast cancer, melanoma, ovarian cancer, bladder cancer, prostate cancer, non-small cell lung cancer. There was a phase 1/2 study done in HER3 positive metastatic breast cancer that showed an overall response rate about 43%, median progression-free survival about 8.3 months. So really kind of promising activity in this subgroup of patients. And so in lung cancer, there really is an emerging role for HER3 and TRP2. With HER3, it's frequently overexpressed in non-small cell lung cancer. U3-1402 is an investigational HER3 targeting ADC. And as discussed earlier, neuregulin binds HER2, HER3 as a heterodimer and leads to downstream signaling. And so when you have an NRG1 fusion, that leads to constitutive neuregulin upregulation, activation, and the subsequent downstream consequences in non-small cell lung cancer, an anti-HER3 strategy may be particularly provocative. And so a phase 1 study of U3-1402 has been conducted and is being conducted in unresectable non-small cell lung cancer. And preliminarily, there's been a very manageable safety profile with promising activity, which I hope we'll see more updates on, because this is a very unique tumor population that doesn't really benefit from traditional approaches of chemotherapy or even immunotherapy. One other point about NRG1 fusions is that they're really best detected by RNA-based testing. So we're talking about protein-based testing with immunohistochemistry. We're talking about DNA-based testing, whether liquid biopsy or tissue for amplifications or mutations. Here, to best detect an NRG1 fusion, you actually have to do tissue-based RNA sequencing or something similar like Archer to detect for fusions. With TROP2, which is trophoblast cell surface antigen 2, this is a transmembrane glycoprotein that's highly expressed in multiple tumors: triple-negative breast cancer, non-small cell lung cancer. And there are ADCs in development to target TROP2. Sacituzumab recently had an FDA approval in triple-negative breast cancer, in fact, and a fast-track designation in non-small cell lung cancer and small cell lung cancer. And then DS-1062, which is another TROP2 ADC, which has a phase 1 in non-small cell lung cancer underway. And so with that, I'd like to ask Dr. Janjigian and Dr. Hamilton their thoughts on some of these agents within their disease and their biology, and then have Dr. Hamilton continue to lead the discussion here.
Yeah, absolutely. So, as you mentioned, sacituzumab govitecan has now been approved in triple-negative breast cancer. I think it's very exciting in triple-negative, just because we've not had really traditionally targeted agents. Atezolizumab with our first immunotherapy approved for triple-negative, and again, is in a subset of patients, not the traditional all-comers that we see in some other tumor types. And then certainly to now have a TROP2 antibody drug conjugate. Traditionally these women with triple negative disease really only had chemo, and more chemo. So it's very encouraging to be able to get some targeted agents out there. Dr. Janjigian, I'd like to ask you a question. You had mentioned in your talk really about a certain study that had serial biopsies and that the HER2 expression was lost over time. what do we know in GI cancers or other cancers, if anyone else would like to pitch in as well, about acquired HER2 mutations or the percent of time we see HER2 amplification or expression change over time?
Thank you for bringing this up. That's a great question. What we know from several studies looking at serial biopsies and also circulating tumor DNA or the liquid biopsy assessment, that over time HER2 expression changes in gastric cancer in approximately a third of the patients. So in 30% of tumors, HER2 expression goes from positive to negative. Occasionally, we do see also, and there's some data coming out of Japan and Korea, that previously what patients were thought to be HER2 negative were on subsequent biopsies found to be HER2 positive. That is mostly related to tumor content and also heterogeneity within the patient's disease. So we do see in gastric cancer at times, if the primary tumor, for example, is HER2 positive, the liver metastasis may be HER2 negative because of the dedifferentiation of gastric cancer from intestinal type to pleural differentiated type over time as the disease biology becomes more aggressive. So there is both temporal but also spatial heterogeneity in HER2 expression, which makes liquid biopsies or circulating tumor DNA an important tool for us, and is now we're routinely doing in at least academic centers in the clinic to understand the heterogeneity of the disease. Co-occurring alterations within the HER2 space, or so-called HER2 mutations, do occur in gastric cancer. Those are rare and generally happen in quote-unquote HER2 negative cases, so in patients that are IHC and FISH non-amplified. And it's probably a separate topic. Outside of clinical trials, some have used TKIs, and also certainly in phase 1 in basket studies, HER2-directed agents such as Neratinib and Afatinib have been explored in those settings. Unfortunately, by the time the patient goes on these basket studies, they're typically quite ill and heavily pretreated. So to date, monotherapy with these TKIs has not been shown to be meaningfully effective or active clinically in this population. But this is a HER2 amplified and HER2 mutant population, similar to what has been described by other speakers, is distinct in gastric cancer. Wanted to say a few words about HER3 mutations in gastric cancer, as everyone was very excited because on the TCGA and the NCI Genie project, HER3 appeared to have been potentially, a target in gastric cancer. But unfortunately, so far, the clinical trials, again, in heavily pretreated population, have not been all that promising, likely because monotherapy targeting in gastric cancer is not going to be an effective strategy. There, more so in any other diseases, there's RTK activation almost within days or weeks on therapy that is noted. We did a trial with Afatinib in gastric cancer that was published in Cancer Discovery, where patients with ERBB2 and co-occurring EGFR amplifications had a dramatic response to Afatinib, but within 2 months on therapy, 2 of the patients developed a high level of MET amplification, for example, that was then driving the resistance. And so with gastric cancer in particular, there's quite a bit of the whack-a-mole analogy going on with these RTK activation and downstream and parallel signaling. And so that's why combination strategies and also chemotherapy-based backbone continues to remain as the main important research strategy in our disease.
Great. Thank you so much to all 3 of you. We're going to take some questions from the audience listening here. I may phrase this one initially to Dr. Wagle. How is HER3 testing carried out, and are there preferred methods for that?
The HER3 that we were talking about in terms of testing focus on HER3 mutations. And so similar to the conversation that we had about HER2 mutations, this is something that would be done by sequencing, particularly nowadays next generation sequencing, which would either use DNA extracted from a tumor biopsy or cell-free DNA to look for mutations in HER3. So that's if you wanted to test to see if there is a HER3 activating mutation driving the tumor or causing resistance that could potentially be targeted. For some of these other approaches, for example, in HER2 amplified breast cancer, you wouldn't test for HER3. You're just going to target the dimerization between HER2 and HER3 without testing. And in some of the other cases that were talked about for lung cancer, for example, I'm not 100% clear whether there is a HER3 test. I know for example, we talked about NRG1 fusions where you're targeting a partner of neuregulin. That wouldn't require HER3 testing. And Dr. Patel, is there any other indication for HER3 testing in lung cancer?
Yeah, there is an IHC currently in development. HER3, as you discussed earlier in the discussion, it's a pseudokinase activity, right? It requires it dimerizes in order to have its activity. So definitely next generation sequencing, whether tissue or even cell-free methods can find kinase domain mutations. At least in non-small cell lung cancer, it's an indirect effect, like you mentioned. So we find, for example, the NRG1 fusion, which we know leads to constitutive upregulation of a neuregulin, which is the ligand that binds to HER3. So that's kind of an indirect way. But there is an IHC currently in development as well, which I think may help elucidate some of these patterns we've seen in TCGA and Gini. And also IHC just tends to be an easier way to screen patients, though NGS, I think when you're looking for multiple targets, actually starts to have an advantage in that scenario.
Great. I'm going to pose a question to Dr. Janjigian. I noted that when you were talking about Trastuzumab deruxtecan in terms of GI cancers, they did not have any fatal pneumonitis. That's certainly a little bit different than what we've seen in breast, in the larger phase 1 study, as well as in other tumor types. Have there been any potential risk factors that have been identified or why we may see that change across tumor types?
So the gastric study did not have any fatal pneumonitis. I believe 1 or 2 patients on the colon studies did have it. I think what it comes down to is prior therapy and also chest wall radiation and perhaps ethnicity and the geography of where the patient is from. In gastric and colorectal cancer, the duration of therapy and the number of cycles may not be as long as in breast cancer. The chest wall radiation basically never occurs, and most of our patients have not been radiated. I think some of it is also, at least the data that I'm aware of in gastric cancer, has to do with dose reductions and the number of cycles of therapy. At least in my patients that I'm treating in my practice on a clinical trial, the responses and overall response rate can be quite dramatic and early on in the treatment. And so even if you're not having a lot of toxicity, it may be warranted in those patients to scale back after 4 cycles of therapy or so and decrease the dose to help minimize the risk of IPL.
Oh, and Dr. Hamilton, I think the other point there in particular, and I think Dr. Janjigian brought it up, of course it's related to dose, but I think the antecedent therapies may make a difference, at least in non-small cell lung cancer for other drugs of this class. If a patient had an anti-PD-1, they had a heightened risk of pneumonitis when they subsequently had either EGFR or HER2-directed challenge, and so prior therapies may in fact influence this. And then I think the other point about this and why we're seeing it with TDX as opposed to the other agents is that there is actually low level of HER2 expression in the lung, in the pneumocyte. And in fact, there's a HER2 CAR T cell study in which that study was stopped because of fatal pneumonitis. And so this actually represents the flip side of the same coin. This drug is so efficacious against HER2 that there is actually friendly fire to the level that it causes pneumonitis. That's something, Dr. Hamilton, you've probably given more Trastuzumab than anybody. You may have never seen a pneumonitis in the absence of radiation, but with these next generation agents, they're just so potent. And so it's a sign of potency, but it's something we do have to be careful for in the lung cancer space, at least, for patients who have antecedent immunotherapy exposure.
Great, thank you. And I'm going to send the last question back over to Dr. Wagle to wrap us up before we give some conclusions. Are there any markers being studied that may help us guide the selection among different HER2 targeted therapies, maybe even among different classes, who tyrosine kinase inhibitors versus antibody drug conjugates may work better for you? Or where do you see us heading in that direction?
Yeah, this is a great question, and it's a really active area of study. Because as I said earlier, that all HER2 alterations are not created equal, and as we've just heard, all therapies are not created equal. And so one of the key challenges for us as a community is to think about how we can best match the right therapy to the right genomic alterations or right molecular alterations in each tumor. And some of that may be understanding better which alterations get matched with which tumors. For example, some mutations are completely resistant to certain small molecule inhibitors. And so you can't just say, I have a mutation in HER2 and therefore I'm going to reach for a small molecule kinase inhibitor, because if you reach for the wrong one, it just won't work. And there's very clear evidence that some will work while others won't. Reversible inhibitors don't work well. Irreversible inhibitors might work well. Similarly, the context, the genomic context. So it might not be the marker in HER2 itself, but the marker outside of HER2. For example, the KRAS mutations that we heard about, or other activating mutations downstream in the pathway. And then I think the resistance idea, the idea that this is all dynamic over time, so whatever antecedent therapies you got, or if you've previously seen a HER2 therapy, what might that say to the signaling cascade, and what might have developed to cause resistance to previous therapies, are going to influence our ability to use newer therapies. And that's why it's so important to understand in all these trials whether they're first line, second line, third line, and what the prior therapies were. So I don't have a clear answer to that question, other than it's a huge area of study, and that's the goal of precision medicine, is to really understand what all of the factors are and be able, when you see a patient, not just say you have a HER2 altered cancer, but you have all of these factors, and therefore we know that this drug is likely to work best in you.
Great, thank you so much. So in conclusion, we've heard about HER2 as a relevant target today, not only for those that are HER2 high, but also patients that are HER2 low, and maybe some differences across the tumor types, breast, GI, and lung cancer, as far as amplifications, mutations, and particular agents that have worked or not worked in those spaces. Additionally, we've heard about some new targets, HER3 as well as TROP2. So in 2 sentences or less, I'm going to go around to each one of you, maybe one other thought that you would like to leave our audience with today. Dr. Janjigian, let's go to you first.
Yeah, I'd like to highlight the importance of biomarker testing persistently and early on. The treatment in first-line setting, both for gastric cancer and colorectal cancer, is changing dramatically. So please get these biopsies done and test the tumor, and even if the biomarker rate is low and it feels like it's finding a needle in a haystack, it's definitely an important endeavor to, and personalized medicine is so important for our patients. In second line setting, second biopsy will be critical in gastric cancer, as we're coming into the routine HER2 testing in second line to use HER2-directed agents.
Great. Dr. Wagle?
Yeah, I would have said the same had it not been said before me. But I'll add that on the flip side, which is that we need to make sure we remember and we understand that all of this is influenced very heavily by the tumor type and the context. And as you know, we just spent the last 90 minutes discussing, what we do in breast cancer does not automatically translate to what we do in colon cancer or gastric cancer or lung cancer, and each of these are different. And so that's why so much effort is being taken to understand these in individual cases. And I think the power is going to come from understanding what's different between these different cancer types and these different contexts, and adjusting the strategy accordingly.
Great, thank you. Dr. Patel?
Yeah, I'd agree with all these great comments that we have increasingly a wonderful arsenal of therapeutics that can work for a long period of time and with better toxicity. We used to give chemotherapy to everyone, and we would never give chemotherapy without doing a biopsy to confirm that a patient had cancer to make their diagnosis. And so, similarly, in the modern era, without a biopsy, whether it be tissue or liquid based, to understand their molecular diagnosis, we're flying blind. And so, the ability to get the right test for the right patient so we can give the right drug at the right time to that patient, I think is key. And increasingly, we have tools that let us do that even in a tube of blood. And so definitely, just test, test, test would be my second sentence.
Great. So I'll leave us with the last thought. I think for breast cancer, what's going to be particularly challenging and important is going to be education. We've traditionally gone from where IHC was most important over to FISH, and some institutions don't even run IHC automatically in favor of FISH now. So I think as we get more agents that are going to be active in the HER2 low, we're going to really have to educate and start to think about how HER2 low is actually actionable and think to seek this out on our patients. Thank you so much for joining us.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/VJP860. This activity is supported by independent educational grants from AstraZeneca, Daiichi Sankyo Incorporated, Puma Biotechnology, and Seattle Genetics. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.